Good afternoon or good morning, everybody. I'm sure you're slowly making your way from the waiting room to the Special Focus Dialogue. So welcome you all. It's going to be a little bit of a streaming of our participants coming through, but I hope that you can hear me well. Just a very quick intro for myself, Alessandro from UICC. Welcome to this Special Focus Dialogues on a very interesting topic on caring for older cancer patients during COVID-19. The usual, I'll just do a little bit of a housekeeping before giving the floor to our moderators and panelists, which we're very excited about. First of all, I also like to thank Sanofi for the support that they provided to ensure that this topic of aging and cancer, particularly during COVID-19, comes to the forefront and to give us the possibility to undertake this special focus dialogue. So as usual, I recommend if you could switch on your chat box. We will be using it throughout the conversation, hopefully to engage in some interesting panel comments about the presentation you'll be hearing. And also if you can switch on your participants list and put it in gallery view so you can see the faces of all the people who are coming through. Obviously, we have quite a good numbers of participants from across the world. So maybe before we give the floor to our moderator and panelists, maybe we'll do, I'll stop sharing the slide and maybe we do a very quick engagement from all of you to see from where you're coming from. So my colleague Sinead will now post in the chat box a link in which we will invite you just to give us a bit of a picture of where the participants are coming from. So you can either click on the links that my colleague Sinead has just put there, or you can actually use your mobile and just go to menti.com, menti.com, and use the code noted there. You'll find there a question. We just simply ask you to type the country you're coming from. I think would be quite an interesting, and we'll see just to have a picture of where people are connecting.
I'm just sharing some of the results. So once you've posted, you can come back to the call and you can see all the different countries that are joining us today.
So for the moment, at the moment, it's the bigger the country is, the more participants that there are. So we'll see just this, give us a little picture of where our participants today are coming from. So, which is also very relevant considering that COVID-19 is moving across the world and different countries can find themselves in very different situations. This will also give us a little bit of an input to our panelists to see where the perspective of our participants might be. So nice to see there's countries shaking, United Kingdom, Switzerland, and United States now at the top. But one other important information we'd like maybe to know from the participants is also what type of organizations they are from. Obviously, the issue of caring or supporting cancer patients might be very different if you work for a patient groups, if you are a clinician working in a hospital, if you are from an advocacy team of a cancer society. So it'd be quite good to see maybe the next, the next question on the same link that you can find, just to know a little bit more where you're coming from. So now Sinead will activate the next question. Use the same link, or again, go to menti.com and use the code 386798. Just to give a little bit of flavor to our panelists as well, where our participants are coming from today. Again, because they will be dealing in a different way with the topic that we're discussing today. So just give a few more seconds for people to fill in. And also to say, we will be using this link and this particular code to access menti.com also to collate questions. So if you're using your phone, feel free to keep connecting to this link and use the link to note any question you might have as the panelists go through the presentation. Because I think we will have a space for Q&A and we will take live questions, but it will also be good for the more introvert across our audience to note some questions in advance, and you will also be able to see questions that have already been inputted through their particular platform and vote for them. So I'll give us a little bit of a sense of the questions around the room, as well as picking the questions live. So this will just give us, again, I don't want to take too much time, a little bit of a picture. So we have quite a few people from around hospitals, from civil society organization, and a few patient groups as well. And maybe, Sinead, we can have a quick look again at the countries as well, but then I'll then pass the words on to my colleague Sonali, who can. So Indonesia, Brazil, and Qatar, and Canada, there's quite a few countries featuring up there. So as a last thing now, I would like to, before I give the floor to Sonali, a very quick poll. So I'm going to launch this poll again. We've seen you come from very different countries, from different organizational settings. So you'd probably be dealing with different disruptions that COVID-19 might have caused you. So we just wanted to have a quick touch to get a sense across the room of what type of disruption, what type of impact has COVID-19 done to the services you provide, whether they are clinical service, whether you support cancer patients, whether you do advocates on their behalf. So just to give you a few more seconds to collect a few more of the answers around the room, is also allowing for people to join the sessions as they're coming in. Okay, seems that the questions, some of the answers still coming in. Let me, just a few more. We have 45 people in the room about now, and I've collected around 20 responses. Okay, let's send the poll in there and just share the results. Let's see. So as we can see, that's at least there are certainly the majority of the people in the room have had some level of impact from COVID-19, whether the majority of services have been disrupted or a few services have been reduced. It's heartening to see that nobody's had all the services stopped due to the pandemic. So, and in 3 instances that services are running as normal. So it'll be interesting to see how they come. Probably we come from different countries, and the situation of COVID will be quite different. But I'll stop there, and then I've talked already too much. I shall give the floor to Sonali, who will be moderating this session. Over to you, Sonali.
Yes, good morning and good afternoon, everybody. Thank you, Alessandro, for opening and for giving us some words of welcome. It's really a delight to see all of you online. Thank you so much for joining us. And thank you also to Sanofi for supporting this dialogue and really helping to bring the focus to the issue of a rising aging population and the issues that we need to address in global cancer control. So we have a terrific panel today of people who really know the area of work. We're delighted to talk to them, and we hope that this is an engaging session for all of you. And I think it's very timely. It's very timely for us to discuss aging and cancer. In fact, I would say it's overdue, long overdue, because we've been seeing the increase in cancer cases of the last GloboCan report produced by IARC is showing the rising burden of cancer, that cancer is predominantly seen in older populations. But at the same time, there's really a mismatch in terms of the attitude of health services and the sort of systemic bias that there is towards older populations. So, I mean, globally, we really are experiencing a longevity revolution in which the world's population is aging rapidly. And aging is not just an issue for others, it's all of our issues. It's our issue for us individually as we go through life, but also for our loved ones, our siblings, our parents, our friends, our colleagues. So this is everybody's topic. It is not a niche topic, and it's one that should be really brought into the mainstream. And these demographic changes that we are seeing with an aging population. So now there are currently over 703 million people worldwide above the age of 65, and that equates to 9.1% of the global population. And these estimates suggest that the proportion of the population over the age of 65 is expected to rise to 15.9%, so that's 1.5 billion by 2050. And these demographic changes will have serious implications for health systems, particularly in response to the growing demand for cancer and other NCDs. But it's also an issue of social justice and human rights, as we all work towards ensuring greater equity and access to healthcare and services, and that we push towards the vision of universal health coverage. So in this panel, in this discussion, we're going to be looking at some of the issues that affect older people. And the situation it's very pressing now, particularly because of COVID-19. We've seen through the poll that many of you feel that cancer services have been affected, where the virus is not just threatening the lives and safety of older people, but is also threatening their social networks, access to health services, as well as jobs and pensions. So the time is now for us to act. This is a great opportunity for advocacy. Myself, I am the head of the Knowledge, Advocacy and Policy team at UICC, and one of our main advocacy priorities this year is to look at equity, and which we consider aging and cancer to be one of our core sub-priorities within that topic. So without further ado, I would like to go ahead and introduce our first panelist, who is Dr. Nicolò Battisti. Dr. Batttisti is a Senior Clinical Research Fellow in Medical Oncology at the Breast Unit of the Royal Marsden NHS Foundation in the UK, and is the co-chair of the COVID-19 Task Force of the International Society of Geriatric Oncology. So Nicolò is going to give a presentation, and I see the slide up there. So Nicolò, you have the floor. Thank you.
Thank you very much, Sonali. Thank you very much, everybody. Good morning, good afternoon, and thank you for inviting me on this panel today. My name is Nicolò Battisti. As Sonali said, I'm a medical oncologist. I work at the Royal Marsden Hospital of London. I'm chairing also the COVID-19 working group within the International Society of Geriatric Oncology, which is currently producing a series of recommendations to guide the management of older cancer patients during the pandemic. These are my disclosures. My presentation is really meant to set the scene for our discussion today. I will start outlining the impact of COVID-19 on older cancer patients, and then discuss the general implication of the pandemic on their management. I will also describe the relevance of genetic assessment as a way to better manage these patients in the current circumstances, and then describe also what's the impact on the practical impact on anti-cancer treatment, and then finally draw a few conclusions. Well, first of all, we know that from retrospective data that older patients with COVID-19 tend to be more frequently symptomatic compared to younger adults. But equally, we also know that they may present with more subtle findings when they catch an infection. And sometimes they may experience non-specific symptoms that are actually red flags for the infection, like falls, confusions, and worsening functional impairment. We also know from the earliest reports from China, Italy, and the States that age is a predictor of adverse outcomes of the COVID-19 infection. And this was very, very clear from the very beginning of the pandemic. There are, as you know, a number of analyses that are now looking at outcomes of COVID-19 in cancer patients. This is one of the largest ones, the COVID-19 and Cancer Consortium analysis, which was published on Lancet only a few weeks ago. As you can see here, the investigators collected data from America and Spain on almost 1,000 patients. More than half of these patients, as you can see, were age over 65, with a good representation, especially of solid tumors, but also hematological malignancies. This is obviously real-world analysis, and as you can see, there is a good representation of patients with comorbidities as well, which are increasingly prevalent in the older population. But let me also draw your attention to the fact that almost half of these patients had actually their cancer in remission or non-active, and almost half didn't have any anti-cancer treatment during the previous 4 weeks before having the infection. On the multivariate analysis, obviously, it was evident that age was again a predictor of mortality at 30 days in this population, along with male sex, smoking habit, the presence of active disease, active cancer, as opposed to those with cancer in remission, and also obviously poor performance status and comorbidities. The investigators also pointed out that there were higher rates of deaths without ICU admission in patients aged over 75, and they also outlined that there is a need to accelerate advanced care planning discussion with patients and family during this pandemic. So when it comes to decision making in geriatric oncology, it's also important, it's obviously very important to evaluate what we call competing risks. Older adults may be affected by, a number of comorbidities, may have reduced organ function. They may have higher risk of complication and toxicity on anti-cancer treatments. They may be affected by cognitive impairment, malnutrition, impaired function, polypharmacy. They may lack social support. They may value more quality over quantity of life. And COVID-19 really represents an additional competing risk in this puzzle. So in general, there are different countries, different hospitals within the country has adopted another measure to mitigate the risk of the pandemic here. The social distancing and shielding measures can have a significant impact on all the adults in general. This may affect the provision of supplies, medicine, prescriptions, cause psychological distress, increased risk of malnutrition. And it's also very important, obviously, to try and involve social services, charity if available, set up remote prescribing and drug delivery systems, and also encourage digital literacy to make sure that these persons are really able to get in touch with their doctors or the safety network. Limiting the access of caregivers to hospital is also a major problem in this age group. And this is because this population of patients may have functional impairment, mobility problems, cognitive impairment that can, again, make for them particularly challenging to attend consultations or exams at the hospital. There is really a need to review the needs on a patient-to-patient basis. We may also rely on patient navigators, teleconsultations, although teleconsultation may also be challenging for these individuals. They may have hearing impairment, visual impairment, and again, video consultation may actually work better where possible, where available, as opposed to phone consultations. A number of hospitals have also tried to encourage patients to self-administer systemic agents, for example, for their cancer. But this may be a problem for people with functional impairment, cognitive impairment, polypharmacy may increase the risk of medication errors. And again, we should really looking at individual needs, engage with primary practice and caregiver, and possibly also set up home care teams with, for example, nurses delivering certain anti-cancer treatments in the comfort of the homes of our patients. The pandemic has also put enormous pressure on supportive care teams in the community, which may have a significant impact on symptom control, quality of life in this population. We really need to make sure that we thoroughly address the needs of these patients in clinic, always try and give them a plan B if plan A doesn't work, and again, engage regularly with primary practice and caregivers. So all the cancer patients are obviously very heterogeneous. And for this reason, the American Society of Clinical Oncology, the International Society of Geriatric Oncology, NCCN guidelines, they recommend the use of geriatric assessments in this population of patients when making treatment decisions. Comprehensive geriatric assessment is really a multidisciplinary diagnostic process that can detect a number of problems relevant to the well-being of older adults, comorbidities, function, cognition, nutritional status, mood, fatigue, polypharmacy, geriatric syndrome, and trigger intervention for any problem that may be detected. There is quite a lot of literature documenting a number of benefits of geriatric assessment for older people with cancer. GA can predict complications and side effects from anti-cancer treatments, can predict functional decline, estimate survival in this population, aid treatment decision, can detect problems that are sometimes neglected by routine evaluations, improving the mental health, the well-being, and the pain control of our patients. And there were absolutely compelling data from the recent ASCO 2020 meeting, which obviously went online, showing that geriatric assessment can also reduce the risk of severe chemotherapy toxicity, improve the quality of life of our patients, reduce the risk of unplanned hospitalizations, increase the completion rate of advanced directives, and make postoperative inpatients and ICU admission shorter. Some may think that geriatric assessment, delivering GA in this pandemic may be a challenge, but actually we can rely on telehealth, we can rely on geriatric screening tools that can be less time consuming, and they can also be remotely administered. I put a couple of examples on this slide, the G8 and the VESTA-13. And there are researchers, the University of Rochester SoCare team, for example, in the States, they have set up telehealth as an effective modality to deliver care for this population of patients, including, for example, a pre-visit evaluation, which is phone-based and led by a nurse navigator with some abbreviated questions included in the GA, and then followed by teleconsultation with a multidisciplinary team to make sure we tackle all the problems that this patient may have. What are the implications on anti-cancer treatments in general? Obviously, during this pandemic, we need to ask ourselves a number of questions when considering treatment decisions. First of all, a question related to the patient. What are the preferences of the patient? What are their global health, comorbidities? What's the life expectancy? What's the level of social support? How would they cope with the logistics of that particular treatment decision? These are questions that can easily be answered by implementing geriatric assessments in our routine clinical practice. But also questions related to the disease. What's the biology of the disease? Things are quite different when you deal with solid malignancies as opposed to hematological malignancies. What's the burden of disease, which correlates to the presence of symptoms? Are there, for example, any risk of neurological compromise if I delay surgery for this particular patient? What's the predicted response or disease control on that particular treatment approach? And then question about the treatment. What's the intent? Is it curative or palliative? What's the setting, adjuvant or neoadjuvant? What's the type of treatment that I'm considering? A cytotoxic agent with a risk of myelosuppression, or targeted agents, endocrine or immunotherapy agents. What about the surgery? Things are quite different when we're considering open versus endoscopic surgery, and obviously, what's the setting of the surgery? Is it election or an emergency? What's the dosing of the systemic treatment? What is the route? Intravenous, intramuscular, oral? Can I use G-CSF to prevent myelosuppression on systemic treatments? What's the duration of systemic treatment? When it comes to radiotherapy, it's important to consider also the fractionation of the treatment, and when it comes to surgery, the requirements for resources, anesthetic input, ICU, What's the risk of complication and post-operative morbidity? What's the expected recovery time, the risk of aerosol generated procedure? Are there any alternative options that I could pursue? What's the risk of side effects? And to this purpose, rely on chemotherapy toxicity prediction tools that have been extensively validated in older patients with cancer. And as you can see here, they rely on clinical parameters, lab parameters, and genetic assessment domains. If we look closer to systemic treatment options, there may be quite a lot of scope to adapt their use to mitigate the risk of COVID-19. For example, considering less frequent chemotherapy dosing, such as using a regimen called caputs as opposed to folfots for GI malignancies, or nivolumab and pembrolizumab, which are immunotherapy agents at 4 or 6 weekly schedules. We can also rely on oral instead of intravenous agents, capecitabine versus 5-FU for colorectal tumors. We can consider shorter courses of systemic treatment, 3 versus 6 months of chemotherapy for stage 3 colon cancer, or 6 versus 12 months of trastuzumab for early stage HER2-positive breast cancer. We can also de-escalate treatment, omitting oxaliplatin, for example, for stage 3 colorectal cancer patients. We can also delay systemic treatment where possible. We know that there are data showing that there is a detrimental impact delaying systemic treatment for early stage colorectal cancer, lung cancer by more than 8 weeks, and for early stage breast cancer by more than 12 weeks. We can omit systemic treatment where there are no clear benefits in terms of survival, for example, for all the cancer patients. And this is, for example, the case of chemotherapy for luminal breast cancer in the early stage setting. We may also have quite a lot of scope to adapt radiotherapy in the context of the pandemic based on the evidence available. We can consider shorter courses of chemoradiation for locally advanced rectal cancer, hyperfractionated regimens for early stage breast cancer. There was the fast forward study recently published on Lancet a few weeks ago about this, or prostate cancer as well. Consider intraoperative radiotherapy for early stage breast cancer patients, although evidence here is still quite controversial, but still to spare patients an additional hospital appointment. And single fraction radiotherapy for bony metastases, or in case of metastatic core pressure, which really be the standard of care. We can also delay radiotherapy up to 5 months for early stage breast cancer patients, or 3-6 months for prostate cancer patients, depending on the biology of the prostate cancer, while perhaps putting this patient on androgen deprivation therapy. We can omit again radiotherapy when the benefits are slim. For example, in case of older patients with low risk breast cancer, in the absence again of any documented survival benefit. We can consider alternative option, medical treatment, for example, analgesia for bony pain. And finally, surgery. Obviously, the surgery should be prioritized based on the most effective and minimally invasive procedures available. We should cohort, obviously, patients in surgery in COVID-free areas, favor possibly endoscopic versus open approaches, or procedure requiring local versus general anesthetic. We can delay surgery pending, for example, with the help of neoadjuvant endocrine treatment for luminal early breast cancer, or neoadjuvant radiotherapy for rectal cancer. We can sometimes omit surgery in selected patients. For example, putting patients on primary endocrine treatment for luminal breast cancer if we don't feel that there is a benefit with surgery, or considering stereotactic radiotherapy instead of surgical procedure for selected older patients with stage 1 or 2 non-small cell lung cancer. The main point is really to make sure that you engage with your local multidisciplinary team if available. And this obviously includes oncologists, surgeons, geriatricians, nurses, dietitians, pharmacists, physiotherapy, occupational therapy, social worker, psychology, supportive care, primary care, and now also microbiology and infection control, because these patients have a number of needs that can obviously benefit from the input of all these professionals. In conclusion, obviously COVID-19 has added a further layer of complexity to the management of all the patients with cancer. Decision-making, however, should still be driven by the very same approach that, for example, SAIG have been advocating for 20 years now. Over the last 20 years, we have learned that we should consider not only the tumor biology, histology, grade and stage to drive treatment decision, but also biomarkers. And the same should happen with patients' characteristics. We should move on from simply describing age and performance status, but really look at genetic assessments, life expectancy, organ function, comorbidities, and in the context, obviously, of their preferences. So I would say that, in conclusion, to mitigate the risk of the pandemic, to deliver cancer care to all the adults, I think it is key to know your local epidemiology, because obviously the trends are quite different across different regions in the world. Consider typical presentations, use telemedicine if available. Consider obviously always the bigger picture, look at life expectancy, predicted responses on whatever anti-cancer treatment and in the context of patients' wishes, and also consider a less if more strategy where safe or available. Let me thank all my colleagues from the SAI COVID-19 working group, along with my co-chair, Anna Mislang, that have given an absolutely invaluable contribution to our recommendations that we are hoping to publish soon. And thank you very much for your attention.
Nicolò, thank you so much for that comprehensive presentation. It was very interesting to hear from you this clinical perspective of the impact of COVID-19 in older adults with cancer, and how you have talked about the implications for general clinical management. You've talked about geriatric assessments and treatments and possible solutions. So that was a really, really useful overview. Thank you so much. You've also touched on the patient perspective, and in that we're going to hear more on this very important aspect from Antonella Cardone. Antonella is the director of the European Cancer Patient Coalition, the ECPC. It is the largest cancer patient umbrella organization in Europe, and it has over 450 members from 46 countries. And in her presentation, Antonella is going to talk about the challenges facing older patients in accessing cancer services and care, particularly during COVID-19. Thank you, Antonella. It's lovely to see you today. Over to you.
Thank you, Sonali, and good morning or good afternoon, everyone. I would like to start with an astonishing reality, COVID and ethics. So at one point, a few weeks ago, during the peak of the pandemic in Spain in mid-March, there was a video circulating online obtained by the Spanish daily El País, showing a Madrid-based doctor telling his team that senior patients may have to be denied care due to limited resources. A similar situation happened in Italy, where healthcare providers had to make a choice on which COVID-19 patients to admit to intensive care units, as there were not enough places for all the infected people. So apparently in some countries, specific guidelines were provided on who to admit and who do not admit, based on the life expectancy and the chances of survival of the patient. It's a thorny question, and there isn't necessarily a right answer. In Spain, the video, the doctor explains that it comes down to prioritizing the limited amount of available care to those who can most benefit from it in terms of remaining life years. The clip published by the Spanish Daily is a dramatic example of some of the intractable ethical questions that doctors were called upon to answer as the pandemic overwhelmed hospitals across Europe. I believe that the situation is not much different in many other countries. So what are the challenges that we are facing today when it comes to elderly cancer patients? We know that more than half of the new cancer cases occur in those aged 65 and older. And this age group accounts for 70% of cancer death. Yet, even in advanced states such as the US, Japan, and countries within the EU, health systems are not always identifying the specific needs of older people living with cancer or defining individualized care pathways for them. So there is absence of adequate evidence and more research is needed on the best ways of managing and treating older people living with cancer. The lack of sufficient geriatric expertise within the oncology specialty is another challenge. So more training on this specific issue is needed among healthcare providers. And there is lack of multidisciplinarity treatment pathways alongside a limited ability of patients and their carers to contribute to the development of better service provision. I mean, Nicolò before mentioned that we should recommend and we should use multidisciplinary teams, but they are not always available. So at the same time, though, in Europe or across the world, there are good examples of efforts to help older people better navigate the process. And this is where it would be great to hear from you during the discussion. I hope that besides the questions, you will also bring up your good practices around the world. So specifically on COVID-19, the causes of COVID-19 related deaths are not clearly defined yet, but data from Italy showed already in the first weeks of the outbreak that more than 20% of all COVID-19 mortality was among cancer patients, and the majority at the beginning were elderly. If we consider that as of today, we have more than 10 million cases and more than 500,000 deaths across the world, this sums up to significant figures for cancer patients and justifies why elderly cancer patients are among the highest risk population, and also why they were in the midst of the outbreak rightly advised to stay at home and do not go to see their healthcare providers unless it was strictly necessary. The consequence of this was that the screening or follow-up consultations were suspended for an unknown period of time. And this has generated psychological problems and distress among the cancer patient communities, and even more among the elderly cancer patient communities. But not only that. Studies are starting to come out showing the results of lack of screening and follow-up. In particular, there was a study published a few weeks ago by UCL, the University College London, suggesting that there will be a 20% spike in the number of facilities in newly diagnosed cancer fatalities, in the newly diagnosed cancer patients due to late diagnosis or treatment. The study estimates that a possible 18,000 additional cancer patients may die next year only in England due to the fact that patients were reluctant to go to their GP and to be referred to hospital because they feared catching the virus more than the potential tumors. One of the possible solutions could have been a better use and more extensive preparedness of our health systems to use telemedicine, digital health, and artificial intelligence tools. The use of digital technologies could have helped to support cancer patients at home, and many lives could have been saved during the emergency and in the long run. Unfortunately, though, the use of digital technologies can also cause inequalities, additional inequalities in general, but even more so for the elderly population. So issues like accessibility and usability of telemedicine must be considered and tackled properly, and ideally in a central and systematic way. Ad hoc training should be set up not only for healthcare providers, but also to raise the digital literacy on top of the health literacy of the elderly. So televisit systems are also being used for hospitalized patients to reduce exposure risks for visitors and staff. In Italy, for instance, tablets were used by several patients in hospitals or elderly people in nursing homes. And I stop here because there will be more into this overall discussion. Thank you.
Thank you so much, Antonella, for that very interesting presentation. And I think you've really highlighted with your really shocking example of that bias that is in the health system and has unfortunately emerged, or in this crisis that we are seeing now, to the detriment of the rights of older people to accessing healthcare. So that's a very, very worrying situation, and certainly there have been examples of that we've seen in a number of countries. I think it's also, you posed a very interesting question on how do we change these paradigms and how do we change attitudes. And you also raise a very interesting point on the use of digital technologies and the inequalities that can also be within those, in that we always think that these solutions are available to all, but we go back to the question of the heterogeneity of the older population. So these are really great topics that we can bring up in the discussion. And leading from that, I would now like to introduce you to our third panelist, Dr. Alex Kalache. He is a doctor and gerontologist. He is the president of the International Longevity Center in Brazil and co-director of the Age Friendly Foundation in Brazil. And Alex is going to talk about this broader aging and society perspective, and again, the diversity of needs of the older population, touching on issues such as ageism. So we're really delighted to have you, Alex. You have the floor.
Thank you very much, Sonali. Many of the issues that I would like to make have already been highlighted by your presentation, but also the two subsequent speakers. But what I would like to stress is the urgency that we are faced with. Urgency because we are facing unprecedented rapid aging of populations. This is the context in which COVID hit us. I'm speaking from the Brazilian perspective, but I should add that I have a very broad international experience. I used to be the director of the World Health Organization Department of Aging and Health. And my previous background was academic. I did my PhD with Sir Richard Doll, perhaps the most important cancer epidemiologist in the world. So my focus had been on cancer epidemiology, but always looking from the aging perspective. And what is happening right now is a tremendous challenge. A lot of what you said, Nicolò, makes tremendous sense. I used to live in Europe for 35 years and would fully agree with all that you have set up. I still spend a lot of time in my house in London. I have strong connections with the academia in London. But I'm here to talk about Brazil and other developing countries. The situation is daring. It's very, very different. COVID has not forged the inequalities in this country. It has just opened them up in a very ugly face. The inequalities that we know that the 50% at the bottom of our society only rely on health systems. Health systems that were starting to work much better than in the past, but over the last 4 years, the governmental policies have eroded, and instead of strengthening, they have weakened the response. Against this, we have this tremendously rapid aging. And Sonali, you have called attention, but I would like to add the urgency. We are talking about an increase in life expectancy. When I was born in this country, it was 45, today 77. Today we have 14% of the population over.
Alexander, I
You got
think
mute.
you are mute.
Have I been speaking all this time without you listening to me?
Now, just for the last
About a
20
minute.
to 30
Just a minute.
seconds.
Okay, so I'll repeat that. What we have seen is what we are going to see is this very fast aging in developing countries. And I want you to just, if I can leave a message with you, is the central one. Developed countries first got rich and then got old. We are getting older faster without resources. We are getting older in poverty and tremendous inequalities. I know that Brazil is infamous for the social inequalities, but this is everywhere. Because if you look at countries that receive lots of immigrants from Pakistan or from North Africa or from Latin America, they are also affected by cancer, and they are denying the treatment that their elites will have. So we have a reality that is like a pyramid. If you're at the top in Brazil or elsewhere in Latin America or in Africa or in the poor countries in Asia, you have excellent treatment and you can follow all the guidelines that Nicolò has so well explained to us. But if you are at the bottom, you have to deal with lack of resources and ageism. Is Sophia's choice. Health professionals, even if they are very well trained, they will have to decide. But all this has been exploded with COVID. Our health systems are overwhelmed. And in Brazil in particular, which is the epicenter of the COVID pandemic right now, to some extent, for a question that is very important to bring him here into the fore, is science illiteracy. Our leaders are illiterate in terms of science and cannot make evidence-based decisions. They deny there is COVID. They deny that there is ageism. They don't care if all the people are dying. They say this explicitly, and so what? It is destiny. People are going to die anyway. And only the weak, only the poor, only the aged, and in this country also with racism, that is overwhelming, just present everywhere, only the black. You look at the data from the United States and you look at the data of immigrants dying from COVID, the brown and black faces that care for older people, but are at the back of the queue when it is to receive treatment. So I'm bringing all this because there is urgency. We are not facing the realities the way we need. And in this country, what we are seeing is that there is the collateral friendly deaths. Many thousands of people that we know are dying for lack of treatment, not only cancer, cardiovascular diseases, and all of the other problems, because there is basically one problem, and it is fear. People are in fear of going to health services, especially health services that are not well equipped, that they know they're going to get there with a very high risk of getting back infected. We also have to realize that there is tremendous illiteracy, health illiteracy among the cancer patients. And it is especially high for older people. 1/3 of older people in Brazil are illiterate. And the other third, another third, is functional illiteracy. They cannot cope with all these guidelines. They cannot do properly prevention. They cannot follow properly treatment. And now, if you talk about telemedicine, it's good for me. I can access that. My friends can access that. But for the majority of people, they cannot even go to a health center, let alone have a computer that they can do telemedicine. It's affecting not only health, it is affecting knowledge. It's affecting public learning. Millions of kids in this country and teenagers that don't have access to the facilities, don't have a laptop, or maybe even don't have internet at home. So these are the challenges that we're facing in a government, in a country that has made social inequality even worse than they were before. So the last point that I would like to make is that even before COVID, there has been a lot of ignorance among health professionals. They don't know about aging, let alone about cancer in old age. When I speak to young doctors in this country, and preferably students still at university, I look at their eyes and say, I'm afraid you are going to kill patients through ignorance. So much so that you don't even suspect that you are killing these patients because you have not learned enough about aging. And yet you are going to practice medicine if you qualify in 2020 and work as many years as I have been working. I was qualified in 1970, 50 years ago. If you qualify in 2020 and you retire as old as I am now, you are going to work for 50 years in a country that is aging fast. And it's a failure of medical education. The same for nutritionists, physiotherapists, and whatever. All the health professions are not learning to be health professions for the 21st century. Wake up, because like it or not, you are going to deal with all the patients, be it in gastroenterology, in cardiology, in respiratory diseases, whatever specialty, unless you choose to be in pediatrics or obstetrics, older patients will be the majority of your patients, including those with cancer. So we urgently need a coalition to press for a change in the curriculum. Otherwise, we are going to fail miserably and make the most important social achievement of the last century, which is aging. Aging is good for us. Premature death is what we want to avoid, but we are not offering the minimum so that people can age with dignity and protected with the security that there will be a roof on top of your head, food on your table, and access to proper and dignified treatment.
Thank you so much, Alex. That was really very powerful statements indeed. And really what you're talking about there is the right to health for all people across the life course. And unfortunately, what we're seeing is that in these last months that this has not been upheld as it should be, and it's even enshrined in international human rights law. But there's also a lot I can see in the chat box that people are really agreeing with the point on education, because how do you operationalize that? Really, it's in our society through awareness, but it's also operationalized through the practices and the knowledge of health professionals. So really, what can we do to improve a training of health professionals in geriatric oncology, as you rightly point out, given the burden of disease in this group. So maybe we can talk about that in the discussion further. Now we're going to go to our fourth panelist, who is Dr. Enrique Soto Perez de Celis. Enrique is a geriatric oncologist and researcher in the Department of Geriatrics at the Instituto Nacional de Ciencias Médicas y Nutrición in Mexico. So we're really delighted to hear from Enrique. He's also going to build on some of what Alex has said around the perspectives on cancer and aging from low and middle income countries, looking at some possible solutions both during and after the COVID-19 pandemic has passed, and we're all waiting for that moment to come. So thank you very much, Enrique. Over to you. Do we have Enrique on the phone? I believe Enrique is on the phone line. Hi, Enrique.
Hi.
Hi.
Hi, Sonali. Thank you so much. It's great to be here, and it's great to be invited by UICC to participate in this. And we've had some great talks, bringing in the patient perspective, the physician perspective, and a policy perspective. And what I'm going to try to do is to bring them all together in a practical manner and tell you a little bit about what we've been doing in Mexico, which, as you know, is a low and middle income country, working with limited resources, and how we've managed to continue bringing care for patients with cancer during the pandemic. We have at the National Institute of Medical Science the only public geriatric oncology clinic in the country, and of course we've had to adapt during the COVID-19 pandemic. So as I see it, this is a time of scarcity. What we are facing is that scarce resources are even more scarce right now. As you know, scarcity is an economic concept that says that economic or material resources are insufficient to produce the goods that meet the unlimited needs of the population. And every time our needs are growing faster than our resources. And in this time, it's even more so, because COVID-19 has led to a change in priorities and to new needs, and this has led to systems and hospitals to do sacrifices and adapt their resources in order to be efficient in facing the pandemic. And sadly, many of the things that make geriatric oncology or geriatrics important, this multidisciplinary care that Nicolò was talking about, having patients at the clinic with various providers, having the caregivers with the patients are being sacrificed in order to keep patients safe, keep personnel safe, and keep resources running in a timely manner. So we are currently all working in times of scarcity. We don't have the space, we don't have the time, there is lack of protective equipment in many sites, there is a lack of medication, so we're facing a global shortage of oncology drugs, and this of course is a challenge when we're providing care. There is a lack of social support or an unavailability of social support, and most of all, there is a lack of evidence. So we don't have enough information on how to actually adapt our treatments, and a lot of people are doing just the things they feel are appropriate and doing opinion-based medicine in many cases. And as Nicolò said, this has led to many changes in global geriatric oncology. There have been a lot of changes in treatment, a reduction in clinical visits, stopping screening, stopping follow-up, using what is considered less toxic chemotherapy schemes, which are not always evidence-based, a preferential use for oral medications, which brings some issues that Alex mentioned, such as treatment adherence, etc., and also changes in the way we provide care, using telemedicine, having no people coming to clinic with the patient when needed, and suspending some follow-up care. So in Mexico, the healthcare system was already very strained. I work at a public institution, and at the start of the pandemic, it was decided to transform some hospitals into COVID-19 centers. Our hospital was one of the hospitals that was transformed. And so all care that was not COVID-19 related was stopped, at least in the inpatient setting. So no surgeries, no hospitalizations, no emergency care for patients with cancer. We kept the clinics going, and patients who were already in treatment were still be able to get treatment and to come to clinic. But if they had an emergency, if they needed surgery, etc., we needed to refer to other centers. And as many of you know, in low and middle income countries, the amount of centers that are able to provide multidisciplinary care for older patients with cancer is already very limited. And if you are closing it down and reducing services, then this creates a problem. And one of the things that Antonella mentioned that I think is very important is what's going to come afterwards, because of course patients are going to have to wait months for diagnosis. And even though screening is an issue, I think the main problem is access to care. So fear, lack of availability of services is going to reduce access to care for a population that was already facing a lack of access to care. And older adults live in an inequality within an inequality. Even in unequal countries like Mexico or Brazil, older adults face additional inequalities because the healthcare system is not age-friendly, and now with COVID-19, this is more of a problem. So what we've tried to do is to optimize access for older adults with cancer and trying to implement evidence-based solutions to provide care during the pandemic. So one of the things that we have tried to do, and I don't know if you're familiar, is using resources stratification. Resources stratification was initially piloted by the Breast Health Global Initiative, and it's a series of guidelines that takes into account what the resources of a setting are in order to provide evidence-based care. And it divides resources into basic, enhanced, or maximal. And depending on the availability of things that you have to do, then you can institute different treatments that provide additional gains to patients. So I think this is a good framework to think about, because this is an evidence-based framework that allows you to do things with what you have available. So if you have surgery available, but you perhaps don't have medications, then you can tailor your schemes in order to provide good treatment without giving chemotherapy. As someone mentioned in the chat, for example, neoadjuvant endocrine therapy or primary endocrine therapy, and all of these things are evidence-based and are within guidelines that perhaps are not the guidelines that you use in cancer centers in high-income countries, but that have evidence and provide benefits to patients, reducing the risks. Another very important thing that was mentioned is telemedicine, and this was mentioned by all speakers. So of course, providing telemedicine to older adults with cancer is an issue because we have worries about health literacy and about technological literacy. And of course, computer access is very limited. But I think this is a time to think about new novel solutions to implement this. So for example, what we've been doing is we've been using WhatsApp messaging and the video conferencing of WhatsApp messaging. Even in developing countries like Mexico, more than 90% of the population now owns a smartphone. So I think this is a great opportunity to utilize novel media for communication like smartphones. And for example, I specifically have maintained my clinic using the smartphones of the patients or of their caregivers and providing virtual consultations to older adults with no health literacy, many of them who cannot read, live in remote areas of the country, etc. So what's going to happen with geriatric oncology? I think that after the pandemic, geriatric oncology is going to thrive. I think that this issue that the pandemic affects mostly older adults and that people are going to have to make choices regarding aging, comorbidities, etc., is going to bring geriatrics to the forefront eventually, and we're going to be more necessary than ever. And why? Because we provide help in understanding patients better, in defining the reach and the objectives of treatment, in helping to create a care plan that limits risks to patients and to provider. And of course, there is a very important need to highlight the preferences and priorities of patients who are offering treatment. And these competing risks need to be brought up. And this is something that geriatric oncology and geriatrics in general can help bring along. And of course, integrating family and caregivers. I think that crises are a great opportunity for innovation. And I think that this is also a good moment to stop the low-value practices that we were doing before. We had a lot of low-value practices that we're going to have to limit during COVID-19, and this is going to be an opportunity to do that. And also to develop new ways in which to increase access in settings with scarce resources. We are forced to do that now. So I think this is going to force us to do some things that we knew we could do, but we were afraid of doing. And so I think this is a great opportunity for innovation. And I am looking forward to discussing and to answering many of the very interesting questions that were written down in the chat and in the questions.
Thank you so much, Enrique. There was a lot. I was scribbling some things down there as you were talking. You mentioned so many key points, and one of them, certainly working in advocacy, is don't waste a crisis. A crisis is an opportunity for us to really take stock of what's happening, which amplifies many of the things that we have already been seeing. Many of these issues do not come out of nowhere. There's a long road in terms of the health system capacity, in terms of how health systems are organized, how equity is, how inequalities and equity manifest themselves, and these really come to a head in terms of who is most at risk of COVID-19, but also those people who are dying and those people who have NCDs. We will now wait to see what the pandemic will be bringing in terms of cancer patients, and that data will be emerging over the next weeks, months, and years. There is a task force on cancer and COVID, of which UICC is a participant, and we'll be looking at some of that surveillance data that will show us. We're already seeing, increases in, some worrying, increases in sort of in late detection cases starting to emerge, and the interruption of cancer screening, HPV, and so on. So that's going to then, we're concerned, lead to an increase in the rise of cancer incidence and mortality. So now we have our time for Q&A. So I will then hand over to Sinead and to Alessandro, who, if they could kindly just talk through some of the questions that are coming through.
Sinead, how did we collect many questions on Menti? Maybe you want to share the screen so we'll see what questions have come up on the platform there. Otherwise, we're also happy to take questions live from the audience by the good old style way of raising your hands.
Yes, so I'm just sharing the screen here. I can read out. I think most of the questions so far were for Dr. Nicolò. So everyone was quite interested in his presentation at the beginning, but you can still add more questions as we go through them. So one question here is there any app for the geriatric assessment?
Yes, there are some apps that are including some geriatric assessment tools. I'm gonna share the link in a second in the chat. They're quite handy to use in clinic. There is also the a research group called Cancer and Aging Research Group, CARG. They have a beautiful website with many of the tools that I mentioned during my presentation, freely available online. And there is also another good resource is there is a cancer center in Florida, in Tampa, called Moffitt Cancer Center, and there again you can find on their website all these tools freely available for everybody. I will pop the link on the chat window, and obviously there is also the SIOG website where you can find all the resources that I mentioned and specific guidelines about different aspects of the treatment of older patients with cancer.
Let's see. I'll scroll through a few because obviously we might not have time to answer all of them, but maybe this one. What is the acceptable year definition to be termed as an older cancer patient?
That is an excellent question, really, really good one. Historically, it was 65. Now people tend to think about more 70. But actually, as I probably as I try to hint in my presentation, it's not really about having age cutoffs. It's really about how fit or how vulnerable or frail that person is. Because obviously you may have, people in their 80s that are absolutely doing well with no symptoms, no frailty, no vulnerabilities. And actually, on the other hand, you may have people in their 30s or 40s with a number of different problems. So this is what, for example, within SIOG, we've always been advocating for. We shouldn't be looking at age cutoff as chronological age on its own, but we should be looking at physiological age. So how fit or unfit a person is to make a treatment decision.
Great, thank you.
Maybe I can see some, thanks Sinead, also to make sure we spread the question, some of the question coming up also in the chat. There was a note before an intervention from Luciana on Instituto Oncogui about the importance of the role of cancer NGOs to address this issue, also as a response to what Nicolò was presenting about the role of everybody. Maybe I can pick on you, Luciana. Maybe you can tell us a bit more about how you see the role of cancer NGOs in this, and maybe ask a question to the panel.
Oh, thank you, Alessandro and Nicolò. It was great to see the presentation. It's just true that we are trying to incorporate in all the multidisciplinary team our work. It was only a suggestion. So I believe you know about that. So thank you for the opportunity, Alessandro.
So maybe a question from the panel: how do you see the sort of the civil society working in cancer and advocating in cancer? How can they support the work that Enrique was highlighting what Alexandre was saying as well. Maybe a question for the panel.
Maybe I can try and answer.
Please.
Let's see if I can also get my video on. Yeah, so, well, I believe that we definitely have a very, very important role to play. First of all, in providing reliable information and accessible information to cancer patients, because you know that I'm sure that you know that what is accessible and understandable by healthcare providers needs to be translated to a language accessible to cancer patients and to policymakers. So this is a role, an important role that we can play in making what is already available in terms of research, papers, information accessible to cancer patients and policymakers. Then we can make sure that the cancer patients and elderly cancer patients are empowered to advocate for themselves, because who can better advocate for a cause than the person who's discriminated in the first place. So that is another important role that we can play. Then when it comes to telemedicine, for instance, this is a practical thing. Well, there are a lot of challenges linked to the use and usability, accessibility of telemedicine for the general population, more so for the elderly. But then we need to be at the forefront to make sure that we do not ignore that telemedicine, artificial intelligence is going to be the future. I mean, if you look at COVID-19, if we were prepared, a lot of less people could have died just because of the use of telemedicine, accessibility, more application. Like we could have avoided the people to go to the emergency in the first place if we had a system in place. So I believe that we should not ignore the opportunity, but we should be at the forefront to support our patients to use telemedicine, and so to find ways to provide this cancer or health literacy, but also digital literacy. I stop here because otherwise I can go on. I mean, there is so much that NGOs and cancer patient organizations can do to support not only cancer patients, but also policymakers and healthcare providers.
I have one question myself, and I'd also be really interested to hear from the other participants. If you have any questions, don't hesitate to also speak or raise your hand. Sinead and Alessandro can identify you. Is the mental health burden on older cancer patients? What has been the burden? How have older patients reacted, many of whom are living on their own, don't have family nearby, unable to go out, don't have that support network, not, given the heterogeneity of the population, not all are internet literate, etc. Can the panel give some insights into that? For example, Alex Kalache, do you have any comments on that? I'd also ask the other panelists if they have anything they'd like to add, Nicolò and Antonella, on that topic of the mental health issue.
COVID has also exposed the fact that we in Brazil have over 3 million older people living alone, and you have another 4.5 million people, older people, that live only with their partners. So we put this together and we have about 7-8 million people that are very isolated. To reach them out is difficult because we're talking about telemedicine. It's they have a total barrier here to access. So in the immediate future is the campaign that we are doing here in Brazil through my center, is express your solidarity to your neighbor who you know is old with diseases and is alone, is afraid, is in fear, is grieving, not only because somebody he or she knows has died, but grieving for the lack of hope and future. People are going through this in very dark moments. In the longer term, we have to fight populism. Loneliness and the anxiety that it brings is not to be responded like in the UK, create a minister of loneliness. The same government that closed 800 public libraries in the very same year that the ministry was announced. Do we need new bureaucrats to deal with loneliness? But then we close the public libraries, which is where all the people or single mothers or people with mental health problems go in order to fight loneliness. So I would like to put this together and reply to your question, which I know it's broader, but just to focus on the most vulnerable, people that live alone, are vulnerable, maybe they don't have families. And it's not good enough for governments to say the family, it is the family's duty to look after. What family? Fragmented family, more divorced, immigrants, people that live their old parents. You have just seen what has happened. Carers from Ecuador that were providing care to older people whose families cannot deal with the problem of caring for their older relatives. So they outsource poor immigrants, unqualified from Ecuador or Bolivia or wherever. And they brought the virus back home that killed their own parents who had been left behind in Ecuador or in Bolivia, looking after the grandchildren. So the only way for this woman to have gone to look after older people in Spain was because their mothers in particular were looking after the children left behind. That is just to expose the inequalities that are not only at the national level, but at global level. And in the long term, what the message is that we have to, especially with this very fast aging, to deal properly with inequality.
The other two panelists would like to comment.
May I add something?
Please, Enrique, yeah.
Yeah, so I think that what we're seeing in everyday clinical practice is that this is happening at an alarming rate. So our patients are feeling anxiety, they are feeling depression, and also I think what we are going to see in the future is that a lot of patients, since they are inactive, they are at home, they have stopped doing a lot of their instrumental activities of daily living, they have stopped going outside, they have stopped social interaction. So I think we're going to see a lot of functional decline after the pandemic is over, and some of our patients with cancer or cancer survivors are going to have new issues related to this functional decline. So I think that after the pandemic is over and when we start easing restrictions, one of the things that's going to be very important is to do to focus on rehabilitation, bringing patients back and trying to bring patients back to a good functional status, etc. Because that's the burden of disability is going to grow tremendously after the pandemic, and that's something that we have to think about in our patients who are cancer survivors.
Thank you so much. Thank you so much, Enrique. We have a question from Dr. Hadi. Dr. Hadi, you have the floor. Go ahead, please.
Thank you so much. I just want to stress on the point that you guys mentioned about the NGO and involvement in cancer care. NGO could be involved, and they should be involved in all spectrum of cancer continuum of care. They could be involved, and I think in this time they should be involved in every step. And I think Alessandro can remember that in the training that we had in Oman previously regarding regional leadership. And the national and the discussion that we had regarding the National Cancer Control Plan, the NGO should be implemented, and they are part of the National Cancer Control plan from the beginning, from the implementation, from designing, from the NGO, I think nowadays proven worldwide that they could actually fill a huge gap that exists in the healthcare system. And more and more should be recognized and be partnered in the even designing and implementation aspect.
Thank you very much, Dr. Hadi. I also see a comment here or a question from Oleinka Odumosu to everyone who's asking, you know, what is the hope for low and middle income countries, especially because not all older patients have access to a smartphone or can afford it. And I think actually now that leads us to something that we had wanted to ask our panelists, which is to really give us three advocacy or policy areas that many of us are advocates listening into this we should focus on. So you have really just 1 minute each to say something around which 1 to 3 areas, policy areas, we could be focusing our advocacy efforts on. Let's start with Antonella.
Sonali. So for me, the biggest priority, also based on the discussion today, came out very clearly, is on addressing cancer-related complications and comorbidities. You know, mental health, obesity, physical activity, nutrition, aging, those are all cardiovascular conditions, cancer-associated thrombosis. I mean, there are several. They all should be looked at in a systematic way. Then, of course, a multidisciplinary approach that is fundamental. And I would not leave out telemedicine, because yes, there are patients who don't even have a phone, but to the health system, a phone would be much, much cheaper than, for instance, sending a doctor systematically to the home, or risking the life of a patient to go to the hospital, just to mention something that we could face.
Thank you very much, Antonella. Thank you so much. Alex. You've got your mute on, Alex. There we go. Still on mute. Perhaps I can unmute. Yes, there you are.
I have not done that. It was Alessandro. I can blame him. Let me say just one thing. There is hope. Brazil 40 years ago was a country where most males smoked, and increasing the rate of female smokers was fast increasing. It was about 43% in total. Today we have less than 10% of the people who smoke. So we can deal with the problems and challenges from a preventative point of view. The role of NGOs is absolutely fundamental, but we need well-orchestrated policies coordinated at high level. We need to bring this education to policymakers. And above all, I think that we have to train all health professionals, those that are already in practice and those that are going to graduate within the next 2 or 3 years, to bring a very strong element of aging education. Otherwise, they will continue to kill patients in ignorance. They don't even suspect they are doing it.
Thank you, Alex. Nicolò.
Yes, thank you. I think my main 3 points are really, well, first of all, it's pretty clear that when it comes to all the adults with cancer, one size does not fit all. So I think, you know, we should really be speaking to different governments, and, you know, because the trends are clearly different in many different countries. We can make decisions that are valid for all settings. Second, we have you know, a massive wealth of knowledge and advocacy, which are, as you mentioned, NGO, professional society. Again, I'm part of SAIOG. We should really be talking to each other to identify the areas which are most relevant. And third, yeah, I like Alex said, education is absolutely key. I trained in my own country, which is Italy. I didn't have any formal training in geriatrics doing my specialty training in medical oncology. I got more knowledgeable in the field because I sought some training in geriatric oncology at the Moffitt Cancer Center and so on. But this happened because of a number of fortunate circumstances because of my choice. But actually, all oncologists actually would see the majority of patients that they see are older, not younger. So I think education of professionals, not only oncologists, but also pharmacists, nurses, whoever deals with patients, older patients, is really key.
Thank you so much, Enrique. And then we have just a couple of minutes left. Enrique.
Yes. So if I would have to say three things I think should be modified is including geriatric training for all healthcare providers. I think we've seen that healthcare providers should have some geriatric training in order to make decisions during these difficult times. Creating and fostering the development of information and communication technologies that are affordable and accessible. I think that's a low-hanging fruit. The smartphones are incredibly cheap nowadays, and I think that's easy to do. And finally, I think this is a good opportunity to reduce a lot of low-value practices. I think healthcare systems should reconsider many of the things that we are doing that are not actually helping our patients and just increasing the burden financial and system-wise on patients. So I think those will be my three top priorities after the pandemic.
Thank you very much. And I see there's a very active chat box happening here. Unfortunately, because of time, we're really at our last minute. If only we had more time to go through all of these. But I think, we have one point here from Sheila Nair, who has talked about the importance of, say, community health centers as sort of filling as an important step. And that really points to the importance of primary health care. So that is a very key aspect of the health system, particularly for older population. So that's a good point there. We're running out of time. I would like to hand over to Alessandro. I just want to thank our wonderful panelists and the participants. Alessandro, please, your turn.
Thank you, Sonali. Well, we wanted to end a little bit this session on possibly on a positive note, and me asking all of you to contribute. We've seen all the challenges and the serious impact that this is having on all the work that you're doing and on cancer patients, particularly the older populations. But maybe taking a lift of what Enrique was saying in terms of that he believes that after the pandemic, geriatric oncology is going to thrive and see this very much as an opportunity. Maybe I'd like to ask each of you to type in the chat box, what is the opportunity that you see coming out of this crisis? And just give it a few more seconds of thing and input what could be the opportunities to make our health systems more age-friendly that can come out of this. Trying to move away from focusing on the huge challenges that you have. So if you could take a few moments just to type your answer on the chat box, but if I can ask you to refrain from pressing enter immediately, but just waiting that possibly everybody has had the time to write, and then we all press enter all together, and we see a little bit of a cascade of small opportunities that might arise, and we can finish on that particular positive note. So while I give you some time to reflect on what is the opportunity coming out of this, I'd like just to thank Sonali, who's moderated, and to thank Nicolò, Antonella, Alex, and Enrique, who have so kindly shared their expertise on the panel. And I would like to thank Sanofi for their support to this webinar and to the theme of cancer and aging. This is just a start. We will address the issue in different ways, and there would be further dialogues on this, also given the high participation there has been. So now I hope you've had all the chance to write, to highlight your opportunity. So I would like to invite each one of you to press enter, and hopefully we'll see quite a few of positive solutions, the silver linings, as I like to say, appearing on the chat box. And we will share, a recording will be available of this webinar. We will share learning out of it, and also I'll make sure that to capture all the learning that has come out from the chat box, and making sure this is spread along all of you. So see some of the solution coming through. The use of telemedicine, certainly something that has appeared in the conversation, multidisciplinarity. Few more entry there. Well, hopefully we'll capture all the silver linings that have come out through the chat box, and I'd like to thank you finally also all the participants that have stayed till the end, and apologies if we run a little bit later than the 90 minutes predicted, but I think that will be all for us. You'll find all the learning from this platform, from this conversation on our website, and you'll hear about how to follow up on some of the very interesting ideas that have come up. Thanks to everybody for participating. Keep safe and keep up the great work you're doing.
Thank you, everyone. Thank you to our speakers. Thank you.
Thank you.
Thank you very much.